Today, we are holding our 232nd consecutive webinar, which is in which we have great pride. These have been conducted consecutively, as you know, on each Wednesday of the year. And today we have a very important webinar on anesthesia for a pediatric patient. We have had a webinar on pediatric patients. However, this one will be dealing with something new. So they are, of course, we know that they are small patients and they have big challenges. For this, we have very eminent moderators. They are very young and very smart young professors, and I'm very proud to say that. Dr. Chandni Sinha, she is the professor, Department of Anesthesia at AIIMS, Patna, and she is very keen on research. She has a whole lot of publications, and she also has many research papers to her credit. Dr. Nishkarsh, he is at the Delhi, the Onco-Anesthesia and Palliative Hospital, the Dr. B.R. Ambedkar Hospital, AIIMS in Delhi. He is very much interested in onco-anesthesia and pediatrics, of course, and palliative medicine. He too has many publications, and he's the editor of many books. For all of you to know, even the Stolting has been, the Asian version has been edited by him. So big kudos to Nishkarsh, and we are very happy to have both Chandni and Nishkarsh as our moderators. Chandni, could you please take over and start the webinar, please? Thank you.
Yes, ma'am. Good evening, ma'am. Very good evening to all of you. Thank you for the kind introduction, ma'am. As all of us know that the needs of an infant and a child is different from those of adults. They have special needs and they require special attention. So we invite our first speaker, Dr. Bhuvaneswari Balasubramanian, to tell us how to approach a pediatric patient for anesthesia. Dr. Bhuvaneswari is an associate professor in the Department of Anesthesia in AIIMS Nagpur. Her areas of interest include pediatric and neonatal anesthesia, ultrasound-guided regional anesthesia, and transplant anesthesia. Over to you, Dr. Bhuvaneswari.
Good evening, everyone. I bring greetings from the Department of Anesthesiology and Critical Care, AIIMS Nagpur. And the topic allotted to me is an anesthesia for a pediatric patient. It's just a brief overview over a very, very extensive topic. Thank you for the opportunity, ma'am. So why is pediatric anesthesia important? It requires specialized knowledge and skills, challenges and unique aspects of pediatric patients where in terms of differences in physiology, anxiety from the patient's point of view, as well as the parent, the caregiver, and the emotional needs which need to be addressed. And our goal should always be ensuring the safety, comfort, and effective outcomes. So let's go over the terminology quickly. Newborn is in the first 24 hours after birth. The neonate is in the first month after birth. Infants would be for first to the 12 months. Toddler would be 1 to 3 years. Small children 4 to 12 years. Adolescents would be 13 to 16 years. What are the key anatomic differences that we need to remember while dealing with pediatric patients? Smaller airways with increased risk of obstruction, larger tongue relative to the oral cavity, higher larynx position C3, C4 versus C4, C5 in adults. Narrowest part of the airway being the cricoid cartilage in children versus the vocal cords in the adults, and underdeveloped musculature which affects the airway stability. So overall, this causes a lot of respiratory perioperative concerns for us. Physiological differences, the key ones being higher metabolic rate and oxygen consumption, immature thermoregulation leading to rapid heat loss, increased heart rate compensating for the reduced stroke volume, immature liver and renal functions affecting the drug metabolism and excretion, and lower functional residual capacity and a higher respiratory rate, making them prone to hypoxia. Pharmacologically, there are altered drug absorption, distribution, metabolism, and excretion because of the immaturity of the liver, reduced protein binding due to lower albumin levels, increased sensitivity to the anesthetic agents, differences in the volume of distribution, higher water content in neonates and infants, and prolonged drug elimination half-life in neonates. So how do we approach a patient? In the preoperative assessment, what are different from that of adults. The birth history would be important, the growth milestones, the delay or the development overall, chronic illnesses. In the physical examination, airway assessment, nutritional status would be important, anxiety reduction by parental presence, and play therapy. So a structured approach to a preoperative assessment would be to gather the information by you. Most importantly, we need to establish a rapport. In history, important things would be perinatal anesthetic, medical comorbidity and concurrent illnesses, drugs and allergies. Obviously, in children so young, we might not be knowing the allergies. Immunization history, starvation times, previous experience of any pain and medical procedures. Examination point of view, airway, cardiovascular, respiratory, neurological, baseline functional level in children with special needs would need to be documented. Resuscitation as indicated if we find that the child is extremely dehydrated or there are some fluid electrolyte abnormalities. Review the investigations, request any other relevant investigations, optimize the medical condition, formulate the anesthetic plan, including the pre-medication, and deliver the correct and as crisp as possible the information to the patient and his parents, age-appropriate information, role of the parent, risks, consent for specific procedures, an opportunity for the child and the parent to ask questions. So common pediatric conditions with their anesthetic implications that we need to remember is asthma would lead to intraoperative bronchospasm and pneumothorax if untreated and not optimized. So optimum preoperative medical management is essential within if time permits. Common cold would lead to atelectasis, oxygen desaturation, bronchospasm, laryngospasm. So we need to wait till the acute symptoms have resolved before proceeding with anesthesia, ideally for 4 to 6 weeks. If it's a preterm child, ex-preterm, they are at risk of postoperative apnea and anemia. So tailor your anesthesia accordingly, and they need to be admitted even for minor procedures. Seizure disorder might lead to perioperative or postoperative seizure. For patients receiving anticonvulsant medications, then that need to be continued. Sickle cell, you need to avoid any crisis, avoid acidosis, dehydration prior to surgery. So what preoperative investigations should we be planning for the children if they are ASA 1, 2, and 3 to 5? We don't need to go for the entire spectrum of the investigations if not indicated. If it's a minor surgery, just with a full blood count is adequate. Urea electrolytes not routinely, coagulation screen also not routinely, and ECG only if it is a child of ASA 3 to 5 after consultation the anesthetist involved. What is the role of the consent in pediatric patients? Parental guardian consent is legally required. The child assent when age appropriate. Clear communication using simple language. Explain the procedure, the anesthesia steps, the options available if possible. Address the risks, common and the rare complications, alternatives. Parental concerns, you have to encourage questions and address the anxieties. Document, record the consent and discussion thoroughly. And in special cases, follow the regional laws. So what are your preoperative orders that we generally follow? The fasting guidelines would be clear liquids for 2 hours, breast milk for 4 hours, solids for 6 hours. Anxiety management by parental presence, play therapy, pre-medication. Maintain hydration, IV fluids if needed. Medications, if need to be continued, should be continued, essentially keeping in mind the fasting precautions. Infection prophylaxis as per the institutional policy. And pain management, if preemptive is needed, should be provided. So the preoperative ward also should be child-friendly. That helps a lot in psychological preparation by presence of distraction tools and parental involvement. If that doesn't help us, then what pre-medications can we use? Benzodiazepines in the form of midazolam, which can be given 0.3 milligrams per kg, acts within 10 minutes. Clonidine or dexmedetomidine are the newer agents that can be used, which if intranasally 1 to 2 micrograms per kg of dexmedetomidine, which takes about 30 to 60 minutes prior to the procedure. If an IV is in place, then we can give the pre-medications intravenous also. Ketamine can be used, midazolam also can be used. Oral would take 30 to 45 minutes. So what preparation in the OT? Temperature control, most important, maintain the room temperature at about 24 to 26 degrees. Warm fluids, use warming devices, pediatric size equipment, appropriate age size and the weight size equipment should be kept ready. Mask, airways, endotracheal tubes and LMAs. Appropriate size in intravenous cannula and surgical instruments. Monitors also, calibrated pediatric monitors for the ECG, pulse ox and the blood pressure, smaller BP cuffs, and the emergency equipment should be age and weight appropriate. Anesthesia preparation, drugs and dosages as per the weight. Double check all the calculations for accuracy. Fluid management would be taken in detail by my dear friend in the next talk. So use the infusion pumps for accurate fluid administration. Airway assessment and backup plans should always be ready, and your team needs to be briefed about all of this. So what are the routine drug doses in pediatric patients? Atropine 0.01 to 0.02 milligrams per kg. We can use propofol 1 to 2.5 milligrams per kg. Intravenous, all of these are intravenous uses. If we have to consider going for relaxants, rocuronium, vecuronium, atrocurium, or even succinylcholine, all the four can be used in the mentioned doses. So we can always have these ready reckoner charts in the OT for calculating the doses so that our students are easily ready for the child. Other preparations, team readiness, the specialist involvement has to be there in trained pediatric anesthetic and surgical team. Communication protocols, everybody is briefed about the child's medical status. Post operative setup, recovery area also needs to be warm and should have all the resuscitation and the monitoring equipment ready. So what would be your anesthesia strategy? Generally, we can go for a mask induction if IV is not present, or intravenous propofol or ketamine can be used. Maintenance would be by balanced anesthesia, volatile agents plus opioids or TIVA when required. And airway management with the age-appropriate face mask, laryngeal mask airway, or an endotracheal tube as per the surgical demand. So how do you quickly go for the estimation of which airway device, what size? Endotracheal tube, internal diameter. If it's a neonate, 3 to 3.5. If it's a 1-year-old, 4 to 4.5. These are uncuffed tubes. 2 years or older, age by 4 by plus 4.5. And at what length are you going to fix it at the teeth? Age by 2 plus 12. Similarly, we have a ready use chart for the laryngeal mask airway as well. So what is the importance of regional anesthesia in children? Why is it important? Because superior analgesia reduces the MAC of the general anesthetic. Neurotoxicity is reduced. Hemodynamic stability is achieved. They rarely cause significant hypotension, reduce requirement of postoperative ventilatory support, obtends the hormonal stress response, reduces the intraoperative blood loss, improves GI function, improves recovery. And for the hospital, easier pain-free children are always easier to handle. Reduce MAC, rapid discharge, reduce requirement of postoperative ventilation, and reduce length of stay. So if you're using a local anesthetic, which ones and how much doses? Lignocaine 5 milligrams per kg is the maximum dose. Duration of action would be 90 to 200 minutes. Bupivacaine 2.5 milligrams per kg, 180 to 600 minutes. Infusion, if you're using for bupivacaine, you have to use in doses of 0.2 to 0.4 milligrams per kg per hour. Similarly, for ropivacaine, 0.2 to 0.5 milligrams per kg per hour. So general considerations for regional anesthesia, they are commonly performed under general anesthesia. The dose is much lower than that for adults, calculated precisely as milligram per kg. Use the local anesthetic with the lowest effective concentration. In case of moderate or severe pain, or if it's a chronic pain situation, consider a catheter technique. And always obtain the patient consent or assent, and also mention postoperative paresthesia in case of blocks. Monitoring, standard monitors with the age-appropriate probes and the size-appropriate probes, ECG, pulse oximeter, capnography, blood pressure, temperature, advanced monitoring if needed, EEG-based monitors, and hemodynamic monitoring in high-risk cases. How do you assess the pain in children? In neonates, we can use the NIPS or the CRY scale, crying, facial expression, body movements. In toddlers, we can use the FLAC scale and simple descriptions which will be easily understood by children. School-age child, Warren Baker faces pain scale. And in adolescents, we can use the numeric rating scale and visual analog scale. So pharmacological management in the form of non-opioid analgesics, opioids, local regional anesthesia. You can use the adjuvants for longer duration and post-operative infusions wherever indicated. Non-pharmacological, we can use distraction techniques, relaxation methods, parental presence, and cognitive behavioral therapy. Also, we need to remember and talk to the parents about the common post-operative events that can happen. So nausea, vomiting, dehydration, electrolyte imbalance, respiratory complications, most common, airway obstruction, atelectasis, laryngospasm, hypoxia, hypothermia, infection, delayed wound healing, bleeding, hematoma formation, cardiovascular complications in the form of hypotension, arrhythmias, and urinary retention. Psychological issues like emergence, delirium, confusion, agitation, anxiety, fear, which need to be, if they are away from their parents or familiar environment. Postoperative ileus, thromboembolic phenomena would be rare, and seizures could be triggered by the anesthesia, metabolic disturbances, or just underlying neurological conditions. So thereby a lot of challenges in pediatric anesthesia from airway management point of view, drug dosing with very narrow safety margins, psychological aspects need to be addressed, and limited physiological reserves. Advances, we can use faster acting, safer anesthetics like remimazolam. We are having a lot of advanced airway equipment now designed for children, techniques in the form of ultrasound guided regional blocks, and updated fasting and monitoring protocols, which we need to be aware about. And to summarize, it's a highly specialized field requiring meticulous planning, pre-operative preparation, precise drug dosing, vigilant monitoring are essential. Advances in technology and the drugs continue to improve the outcome, but most important is keep the parent involved. So a happy team would be a happy kid. And if you face a challenge, do not panic. Do not show any panic. Let's keep calm and maintain the child and the parent. That is most important. And we should always have some quick reference charts in the OT, right from drugs for endotracheal tubes for emergency drugs and equipment. So that would be the end of my talk. These are my references. Thank you.
Thank you, Dr. Bhuvaneswari. It was very concise and informative. Dr. Nishkarsh, could you proceed with the webinar?
Oh, thank you. Thank you, Chandni. So we'll have the questions in the end, like any other webinar, so that we can, some of the answers might be there in the other talks. So all the discussions will be in the end. So now I invite the next speaker. So now we have Dr. Amrita. She is Associate Professor in Department of Anesthesia, BHU, Varanasi. She is a well-renowned speaker and avid interest in pediatric anesthesia and regional blocks. And she has many awards and publications to her credit. So without wasting time, I'll request Amrita to start the talk on fluid and thermoregulation. Over to you, Amrita, please.
Thank you so much, sir, for the kind introduction. So for the next couple of minutes, I will be taking you through the journey of pediatric perioperative fluid and thermoregulation. So I have nil disclosure in this presentation, and I will be covering the topic under the heading of the fluid composition of the body, the types of the IV fluids, the perioperative fluid management, fasting guidelines, thermoregulation, and how to prevent hypothermia. So why this topic is being given and why we are talking, because the physiology, as mentioned by my previous speaker, is a bit different from that of an adult. The pediatric patient, they have a large blood volume, they have large extracellular fluid levels, they have a high metabolic rate and a higher fluid turnover rate relative to the body weight. So what is the concern is, in this patient, if you do underload or overload, either has consequences. So that's why we need to have the optimal range that has to be maintained throughout to prevent the issues of both overload and underload, which is very difficult actually. So first, so F stands for fasting, also stands for fluids. So what is the, first, if we know the objective of our intraoperative infusion therapy, it will be easy for us to manage. So same as I spoke about the physiology, the same thing has to be maintained intraoperative. That is the normal blood volume, we have to try to restore the normal extracellular fluid volume, the normal electrolyte and acid-base balance, the metabolic rate, and normal tissue perfusion. So first we have to understand the fluid composition of the body. So as you see at the preterm neonate, 80% of the total body weight is composed of total free body water. As the age grows, the total body water goes for a decline. And when you look after the total body water, it is like 2/3 is intracellular and 1/3 is extracellular. But what happens to the ratio of extracellular to the intracellular is, as the age progresses, the extracellular fluid component decreases, whereas the intracellular fluid component increases. So if you see at birth, it is as high as 60%, whereas for the neonate, it is 40%, for the infant, it is 30%. As it increases to adult, it goes almost to 20%. So we have to have this consideration that extracellular fluid volume is more in case of an infant, neonate. So next few definition we need to know whenever we are talking about a fluid is osmolarity, which means the number of osmoles per liter of the solutions. Osmolality, it is per kg of the solution and solvent, and that is the osmoles of the solute. Okay, and tonicity refers to the effect of the solution that has on the cell volume. So if we talk about IV fluids, we have been knowing there are two kinds of the fluids, crystalloids and colloids. Again, depend on the tonicity, as I have already mentioned, it can be hypertonic, isotonic or hypotonic. So most common fluid that we are using on our day-to-day is isotonic fluid. So what are the isotonic fluids we know? The most common used are the plasmolite A, the ringer lactates, and normal saline stereofundate. So if you look closely at these numbers, and if you follow this chart, you will see the ringer lactate, whom we consider as isotonic, is actually on a slight hypotonic side. Okay, so we have to keep in this consideration. So the first fluid that is the best is the plasmolite A, which is purely an isotonic fluid. And if the second choice goes, then it RL, because it is slightly hypotonic. And I will be covering this in detail in subsequent slides. Then when we talk about colloid, it can be natural or synthetic. For a pediatric patient, you have to remember the 5% albumin is the best colloid. And if it's not available, and if you wish to go for a second one, then it is better to go for a higher degree starch, that is 6% hectostarch of 130. So next, coming to pre-operative fasting guidelines. We know this magical number of 8642 depending on solids, then breastfeed, top fluid, then breastfeed, and the clear fluid. However, according to the latest consensus which has met on pediatric fluid, which is endorsed by various society, they are of the opinion that you can give up to 3 ml per kg or a small volume till last 1 hour of the surgery. Okay, like if you're scheduling the surgery at 8 a.m. in the morning, you can give a clear fluid up to 3 ml per kg till 7 a.m. But friends, this is for clear fluids only. So the same has been endorsed by AGB as well as the Canadian Pediatric Society. So the newer change has changed from 2 hours to 1 hour. So if I divide the perioperative therapy, we have 3 kinds of therapy: fluid therapy, volume therapy, and transfusion therapy. First, I will be covering the fluid. By fluid, I mean only the crystalloids. So if you think about the crystalloid, you can divide the fluid therapy as the deficit therapy, the maintenance therapy, and the replacement therapy. First, coming to the deficit therapy. So I will be covering this thing under heading of why it is needed, then if it is needed, then what should be given, how it should be given, and what are the precautions. So if I think about the deficit correction, first it is why it is needed. So the deficit, as the name itself suggests, it is to meet the normal fluid requirement over the course of the perioperative fasting time, during which the child is not allowed to drink. That means the patient is following the fasting guideline. Then what should be given? You should give a solution that is isotonic or has the equal osmolarity and the sodium concentration to that of the physiological range. That is why the emphasis is on the isotonic fluid, because this causes the low risk of hyponatremia. So why we are so much concerned about the sodium imbalances? As we know, the tubular function matures till 12 to 18 months of the age, so they are not good in handling sodium. So that is why hyponatremia is a good concern for us. And so what happens in the solution which you are giving, which is hypotonic, that causes a more of shifting to interstitial fluid, and that also causes a hyponatremia. So because of the low sodium, that leads to the neurological symptoms, and that has the potential for seizures, and they have seen that has resulted in poor surgical as well as outcome. So to counterbalance also, we should know that apart from ADH that comes in response to the osmolality, there are non-osmotic stimulation of ADH release, of which hypovolemia is one of the most important cause. So in pediatric patients who have a history of hypovolemia, they do have an increased release of ADH. So that also contribute to fluid overload, resulting in hyponatremia. And the level of the ADH peaks at 6 to 12 hours after the surgery, which tapers over the time of 5 days. So that is the concern. We should use the fluid which has physiological levels of sodium, and it should not be over or under. Second is what to give. So I have already answered this thing. So we should give the isotonic fluid, and that is at an infusion rate of 1 to 10 to 20 ml per kg per hour over the 10 minutes, and it should be adjusted according to the actual requirement. And the patients the child who are at risk of hypoglycemia, they should be given the dextrose separately. So the fluid therapy, whenever you are calculating the deficit fluid therapy, it is very difficult to understand how much the deficit is. So if you have to understand this, if a patient is posted for elective surgery and just has followed the fasting guideline, which I have spoken in detail, it is estimated the fluid deficit will be around 1%. So if you follow this formula, so it is the fluid needed in ml is 10 cross percentage of dehydration, that is 1 into weight. So that is why that number came to 10 ml per kg per hour. And if the patient has come in emergency where you can appreciate there is a level of dehydration, this is a simple chart which, excuse me, sorry for the interruption. So you can follow this simple chart where it is classified as mild, moderate, and severe. Mild is up to a loss of 5%, moderate is 6 to 10%, and severe is more than 10%. So you have to estimate the degree of dehydration. According to that, you have to use this formula and you can proceed with the correction. Second comes the maintenance therapy. So for the maintenance therapy, again, for the maintenance therapy, you should use the Holiday-Seeger formula, which is the 4-to-1 formula. That is 4 ml per kg for the first 10 kilos, then followed by the 2 ml per kg, and then 1 ml per kg. So as I've already mentioned about the non-osmotic ADH release, so the NICE guideline is of the opinion that you should reduce the amount of the fluid that is needed for the maintenance fluid to 50 to 80%, because that is, else there is a chance of fluid overload. Then comes the concept of what about dextrose. So previously, if you remember, we used to use 5D, 10D. Now the consensus is that you should reduce the amount of the dextrose, that too you have to reduce to 1 to 2.5% dextrose. And how do you make 1% is if you remove 10 ml of from the 250 ml of the isolite, means plasmolite A, and you add 10 ml of 25% dextrose, it becomes 1% dextrose. So what was the concern? That the concern was, if there is a hypoglycemia, there will be the release of the counter stress hormone, the cortisol, epinephrine, and the glucagon, which will result in more of a neuronal damage. Also, there will be the conversion to the glycolytic precursor and the Krebs cycle, so resulting in the accumulation leading to a condition of ketosis. Whereas if there is excess of glucose, there will be lactate accumulation. So there will be acidosis that will compromise the cellular function, resulting to the cell death, osmotic diuresis, and electrolyte abnormality. That is why the number that is chosen for the dextrose is 1 to 2.5%, non more or less. And is it needed to give it to all the patient? The answer is a no. Up to 28 days of life, you should give dextrose 1 to 2.5% to the kids. However, after 28 days, only if it is needed. Like if the patient is of a diabetic mother, with hyperalimentation of the gut, or any liver diseases, there only into those patients you should administer dextrose. Then third come the replacement therapy. So why again it is needed? It is to just replace the additional fluid deficit to maintain the normal extracellular fluid volume. Again, what to be given? The same isotonic fluids. Only in certain conditions, like if you encounter a patient of pyloric stenosis where there is a lot of chloride loss, in those cases only you can go for a normal saline. And the replacement therapy has been, the concept of the third space loss has been eliminated in adult studies. However, the current studies are less evident for children, like most studies are yet to come. As of now, you have to remember the number 246, 2 for the superficial surgery, 4 for the thoracotomy, and 6 for the abdomen. And which isotonic fluid is to be preferred? The most cheaper is the normal saline. But the problem with the normal saline is that it contains excess of the chloride, which is and there is no bicarb precursor. So this causes the suppression of the renal renin-angiotensin system, that is reduced in renal blood flow, and there is a chances of hypochloremic metabolic acidosis, alkalosis. And then came the ringer lactate. The problem with the ringer lactate is it has the product that is there is the lactate, and lactate metabolism is via the liver, and you know the liver is not matured. Second, it can interfere with the ABG levels, the lactate that is present in the RL. And third, as I have already mentioned, it is slight hypotonic, so that also can lead to your cellular edema. So the best thing is the plasmolite A because it has acetate, whose metabolism is fast and it has no interference with the lactate level, with the which is like a marker in ABG. So we come to the second part of the discussion, volume therapy. By volume, I mean the colloids. So again, why do we need this? This is to quickly normalize the blood volume, especially in case of circulatory instability or loss of blood. And in patient, it is not to be given as a first choice only when the crystallose is not sufficient and blood product is not indicated, or you are waiting for it to come. That is the where you should use a colloid. 5% albumin is to be preferred, or if it is not there, then you have to go for extra starch of higher degree. And what is the dose that you have to give? 5 to 10 ml per kg. And you should have certain thing like a restricted approach to should be targeted. You have to use the higher generation, as I've already mentioned, and never exceed 50 ml per kg if you are using a colloid. Third part is the blood therapy. So I've already mentioned the neonates and the infants have higher blood volume per kg. So that is why you are more concerned when there is a blood loss. And how do you take a decision? Blood loss is, you have to calculate the maximum allowable blood loss, that is equal to the estimated blood volume into the hematocrit initial minus the final by the initial. So that is how, when the maximum allowable blood loss exceeds 20%, that is the time, or the transfusion trigger, depend it's an acute condition or a chronically patient is anemic, you decide on the blood transfusion. And the transfusion trigger for an infant and above is 7 to 8 gram per deciliter. For a neonate, 12 is the number that is postulated. And what is the volume of PRBC you need to give? That is based on the weight into the desired hemoglobin. Suppose you wish to desire up to 8, now it is 6. So the difference come to 2 into 5. So this is the formula which is to be used for regarding the calculation of the volume of the PRBC. And if the patient is not able to take, the best in the post-operative period, you should try to make the patient eat orally as early as possible. If it fails because of the surgical cause or something, then the same IV fluid that has to be given has to be isotonic, but you have to make it half of the holidacigar. That is, instead of 4:1, you have to shift to 1.5 for the first 12 hours. So for the simplicity of fluid therapy, if you have not understood anything, you can follow the rule of 10. That is the background infusion containing the balanced solution with the glucose to be played at 10 ml per kg per hour. The fluid therapy, again the balanced solution has to begin at 10 to 20 ml per kg. The volume therapy, that is the colloids, has to be given at 5 to 10 ml per kg. And the transfusion PRBC at 10 ml per kg. So it is called as the rule of 10. So just to summarize of what we have studied. So first, if a baby comes, you have to see what is the nature of the surgery, if it is an elective or is an emergency. If it is an elective, you have to see it's a minor or a major. In case of surgery, which is lasting less than 1 hour, there is no need, if the NPO has been followed properly and clear fluid has been given within the last, up to last 1 hour, there is no need to go for infusion, only place a IV cannula. If you see that it's a major surgery, then you calculate the deficit, and if the patient was not on any maintenance fluid therapy, then you can do the replacement depending on the degree of dehydration. Then if it is an emergency, again the same thing, you have to decide on the degree of dehydration, and after completion of the deficit fluid, you calculate the maintenance fluid using the Holiday-Seeger formula. And third, the replacement fluid has to be depend on the type of the surgery. As I've already mentioned, the magic number 2, 4, and 6. And for the volume therapy, for the blood therapy, you have to calculate the maximum allowable blood loss and the transfusion trigger. That is how you would take a decision when and how to give the fluid therapy. Regarding monitoring, you have to keep the patient on monitoring which are on fluid therapy. There are few static parameters and few dynamic. Heart rate, blood pressure, urine output, CVP, CRT, and SVO2 are the static parameters. The pulse pressure variation, stroke volume variation, these are all the invasive or the dynamic parameters. Now we move to the second presentation, to the second topic, that is on the thermoregulation. So we should know in our body, we have two kinds of receptors, the cold and the warm, which stimulates the lateral spinothalamic tract, that in turn activate the anterior hypothalamus, and also the same stimulation come from the spinal cord and the brain. The anterior hypothalamus now stimulate the posterior hypothalamus, which in turn in response to the cold, our body behaves as a behavioral, the cutaneous vasoconstriction or shivering. If it is to respond to a warm, then it will do the opposite thing, again behavioral, cutaneous vasodilation will be there and there will be sweating. So few terminology you need to know when you are talking about the temperature is the threshold temperature. Threshold temperature is the central temperature that elicits a regulatory effect to maintain normothermia. Interthreshold range is the temperature range over which no regulatory response occurs. And we know we have two kinds of thermogenesis, the non-shivering thermogenesis and shivering thermogenesis. So why the concern of thermoregulation comes in children? Because they have an increased tendency of heat loss and less heat production. Why there is the increased heat loss? Because of the thin skin, because of low fat content and high surface area to weight ratio. Whereas there is no concept of shivering till 3 months of the age, and thermogenesis is by the brown fat. That is why they lose the heat more fast and they produce more slow, and the rewarming is 3 to 4 times faster in case of an infant. So what is the mechanism of heat loss? I know most of the time this question is being put in MCQ and most of the people do a mistake. You should remember the most common mechanism of heat loss is radiation. Okay, followed by convection, then by evaporation, and finally conduction. So the concept of non-shivering thermogenesis is, it's a metabolic thermogenesis which occurs in the brown fat, and you can see the location of the brown fat. It is in the intrascapular region around the nape of the neck, and they are highly vascularized and rich in beta-adrenergic fibers, and they work by the mechanism of uncoupling of phosphorylation, oxidative phosphorylation. So if there is a cold response, there is an activation of the sympathetic activity which causes the increase in the lipase activity in the brain, that results in the hydroxylation of the triglyceride and the free fatty acid, resulting in the uncoupling of the oxidative phosphorylation, thereby increasing the protein conduction around the inner mitochondrial membrane, and the heat is released. However, certain main induction agent, as we know, or the pre-medication, the opioids and the IV like propofol, they both inhibit the non-shivering thermogenesis. That is why it is very difficult to control the temperature when the baby is under GA. So the hypothermia that happens during the general anesthesia, that occurs in 3 phases: the internal redistribution of the heat, the thermal imbalance, and the thermal steady state. So first we come, what is the internal redistribution of the heat? So before anesthesia, our surface skin will be 28 to 32 degree, and the periphery will be around 31 to 34 degree. So after anesthesia, what happened? And there is a redistribution of the heat, and the periphery, the heat from the center, the core, moves to the periphery. So the core temperature drop from 37 to 35, and the peripheral skin temperature rises from 28 to 33. So this is how the redistribution of the heat happens in the first stage. So overall, the heat loss is minimal in this stage. Then second comes the stage of thermal imbalance, where there will be increase in heat loss and there will be decrease in heat production. As I've already mentioned, the most common is the radiation conduct and convection, and heat production. Why it will be not there? Because there will be no muscle activity, there will be reduced metabolism and less work of breathing. So that causes a linear drop in the mean body temperature by around 0.5 to 1 degree Celsius. So third comes the stage of rewarming. So the vasoconstrictor response that comes after the 3 hours, and now there will be a reverse shift in the redistribution of the heat. That means the periphery becomes cold and the heat is transferred to the core compartment. That is the time when you feel the surface is cold, and that is too late actually. So you need to go for a quick active as well as the passive thermal compensation at this stage. So because the hypothermia is a very dreaded problem, there will be secretion of the norepinephrine, which will cause the peripheral which will increase the pulmonary vascular resistance, resulting in hypoxia. So via various mechanisms, hypoxia is overall the resultant of hypothermia in OT. So what is the issue with GA? So as I've already mentioned about the concept of the inter-threshold range, that is the normal inter-threshold range is supposed 36 to 38 degree. That means if your temperature goes below 36, our body starts responding by behavior or by vasoconstriction or by shivering. If it goes more than 38, the body again responds by behavior or vasodilation or by sweating. So what happened under anesthesia? This range widens up. Now the body will respond around 34 degree by in response to cold. It will have vasoconstriction or non-shivering thermogenesis or shivering thermogenesis. And as I've already mentioned, what happens under GA, vasoconstriction is not possible. Your propofol or the fentanyl will inhibit the non-shivering thermogenesis, and shivering is absent up to 3 years and not even under GA. So there is no effect on gain also. That is why there is always a high chance of hypothermia in pediatric patient because of this 2 alteration in the thermogenesis. So few definition, what is hypothermia? So there are various definition by NICE, by WHO. So you can always go through any of them, and in exam you can quote the one which you are stating. So these are the different sites for measurement. The core temperature can be measured from the tympanic, and most common what we use clinically is from the nasopharynx, and peripheral is from the skin, forehead, axilla. And how do you prevent prevent hypothermia, you have to remember these magical numbers because these are most commonly asked in exam when you talk about hypothermia in pediatric. So your OT temperature should be 25 and 27 degree for full term and premature newborn. The irrigation fluid which you are using should be 37 to 38 degree, and the relative humidity of the OT should be around 40 to 60 degree. As radiation is the most common mechanism, so you need to have a forced radiant warmers, reflecting blankets, skin warming devices, and your mattress should be set to 40 degree, and you should use humidified and heated gases. So this is the summary slide of whatever I spoke. What is the mechanism? What are the various causes and how do you prevent it? Thank you.
Thank you, Dr. Amrita, for such a nice talk. So we'll, as I discussed earlier, we'll be having questions in the end. So you may stop sharing screen and we'll request Chandni to invite the next speaker.
Thank you, Amrita. That was a wonderful talk. Now, I would like to invite Dr. Anju Gupta, who will be talking to us about neonatal death management. Dr. Anju needs no introduction. She is an associate professor in AIIMS, New Delhi. She has more than 150 publications, editor of Barash and Dorsh, South Asian version. Welcome, Dr. Anju. May you please proceed?
Very good evening, everyone. Thank you, Dr. Chandni, for the kind introduction. Yeah. So my topic for today is the management of tracheoesophageal fistula. As we are all aware, tracheoesophageal fistula is one of the commonest congenital anomaly which we have to deal with in among the pediatric neonatal emergencies. Consider this case: a 12-year-old child, a 12-year-old neonate, 31-week preterm neonate presents to you with a body weight of 1.7 kg. The neonate has a copious oral secretions and complaint of drooling from the saliva from the mouth. And there are complaints of choking, cyanosis, and respiratory distress following the first feed. There was a complaint of excessive frothing from the mouth and bluish discoloration of the palms and soles. And on physical examination, there was a right forearm deformity, mild respiratory distress, subcostal and suprasternal retractions, coarse breath sounds bilaterally, pansystolic murmur, but the abdomen was found to be soft. Attempts at the insertion of nasogastric tubes were unsuccessful in the NICU, and the chest X-ray revealed a nasogastric tube in the upper thoracic region. There was an antenatal history of polyhydramnios. So a provisional diagnosis of TEF with vectoral syndrome was made, and the child was posted for TEF repair. So now let's first understand what is tracheoesophageal fistula. Tracheoesophageal fistula is basically a communication between the trachea and the esophagus. Just a second. Yeah. So it is basically a failure to form a continuous passage from the pharynx to the stomach, the esophageal atresia, and the tracheoesophageal fistula and esophageal atresia. The incidence the prevalence is around 1 out of 2,500 to 3,000. So it is a fairly common anomaly. And 20 to 30 to 40% of these infants are premature and or small for gestational age. There is we have to understand that there is a huge difference when it comes to premature versus term. So we have to carefully elicit the gestational history, and there is a high mortality for premature as compared to term infants. And 20 to 25% of these infants have additional congenital anomalies. Embryologically, this is basically a separation defect. We know that there is a common origin for the tracheal, for the respiratory system and the esophagus. So trachea and esophagus, they develop from the foregut, and for this in the 4 to 5 weeks of gestation, the tracheal primordium, it develops as an outgrowth from the foregut, and at around 4 to 6 weeks, there is a incomplete separation of the of the trachea from the tracheal groove from the esophagus.
So any interruption in this normal event will lead to tracheoesophageal fistula. No classification, this Gross's classification is the one which is most commonly used. And in the Gross's classification, the type C, where there is a proximal blind esophagus pouch and distal communication between the trachea and the esophagus, that is the commonest anomaly with an incidence of 80 to 90%. And there is another type F, which is only plain esophageal stenosis. Then there is a walk classification, which is also sometimes discussed. So it is more or less same as compared to the Gross's classification, with an addition of this walk 1, which is known as the esophageal agenesis, and where there is a no fistula. Whereas in Gross classification, the type A is basically a esophageal atresia. And additionally, in Gross classification, there is a type F, which is only plain esophageal stenosis. So we have various anomalies which are associated with the this tracheoesophageal fistula. And out of these, I have already mentioned that cardiac anomalies are the one which lead to highest amount of mortality. And among them, VSG, PDA, tetralogy of Fallot, and all these are the commonly associated ones. And Vectral syndrome is basically a constellation of anomalies which are associated commonly with the tracheoesophageal fistula, and it is associated in 10% of the cases. Other anomalies are Chard syndrome and Scheisses. And among the genetic anomalies, trisomy 21, that is Down syndrome, trisomy 18, and 13q deletion are also associated. So coming to the vectral syndrome, we should, whenever a child of tracheoesophageal fistula presents to us, we should actively look for these additional anomalies which may be associated, like vertebral anomaly, anal anomaly, like imperforate anus, any malrotation, any duodenal atresia. These all come under the anal anomaly. So, and then cardiac anomalies, they have an incidence of 20%. VSG, PDA, TOF, ASD, right-sided aortic arch, all these anomalies can be associated. Renal anomaly may be related to a renal agenesis and or dysplasia on one side, and then hypospadias, polycystic kidney disease. These all are counted under this head. Then radial anomaly are commonly associated among the limb anomalies, and I have seen these kind of cases. Polydactyly may be associated, and lower limb defects may also be associated. So out of these anomalies, if 3 are present, we label the child as a vectral syndrome association. So then this child prenatally, this child, if the child presents to you with this typical syndrome, sorry, I am lost. Just a second. My screen is not visible. Sorry. So, sorry for the interruption. The child will present to you with the clinical presentation, maybe the prenatal history of polyhydramnios or absent and small stomach bubble. At the birth, you will see the history of inability to pass the suction catheter. There will be a history of excessive salivation, cyanosis and with the feeds, and cyanosis and choking with the feed. This is a typical triad associated with tracheoesophageal fistula. Now coming to the differential diagnosis, whether it is esophageal atresia only or esophageal atresia with proximal TEF or distal TEF or TEF only, we will see in plain esophageal atresia, there will be an inability to pass the suction catheter within 10 centimeter from the gum line, and there will be absent of, there will be no air in the GIT. That will be a gasless abdomen. Then esophageal atresia with the proximal tracheoesophageal fistula, then the child will regurgitate every feed, and there will be a typical triad of coughing, choking, and cyanosis with every feed. Now, the commonest anomaly is esophageal atresia with the distal tracheoesophageal fistula, which is where we will see there will be we will not be able to pass the suction catheter beyond 10 centimeter. There will be a tympanic abdomen. The air will be there in the GIT. That is differentiates it from the plain esophageal atresia or esophageal atresia with the proximal TEF. Whereas in a case of TEF only, that is a H type of fistula, they may go on till adulthood before it can be diagnosed, and they may be having a recurrent history of pneumonitis, and abdominal distension may be there. मेरी slide नहीं change.
बीमार है Anju ma'am, you're on mute, I think.
She was having some trouble changing the slide. I think she's just figured it out.
I think I'll just unshare and then share it again.
Yeah.
My slides are not moving. Yeah.
Yes, ma'am. Yes.
Apologies for the technical glitch. So coming back to the talk again. Coming to the pathophysiology, the two most important pathophysiological entities in a neonate with TEF are presence of dehydration and aspiration pneumonitis. Because the saliva and secretions, they keep on accumulating in the upper esophageal pouch, and there may be a continuous, continuous aspiration to the lungs. And
Ma'am, we are
contamination
just
of the
seeing
lung
your
can result from the spillage of the gastric contents through the distal tracheoesophageal fistula also.
Anju
So
ma'am, only your
these
serious
child will
slide is
not be
visible.
able to be fed well, and also there will be. Oh.
Yeah.
Dr. Anju, could you please change the slide?
Are my slides changing?
No, we can just see your CVE slide.
No, you can just see. I'll just stop sharing and again share. Is it visible now?
Ma'am, can you take it on full screen mode? Yes, ma'am. Now they are changing.
They are visible? They are changing? Yeah.
Yes, ma'am. Yes.
Okay. Okay. Sorry for the interruption again.
Yeah. Yes, ma'am. Can we have the slideshow mode, ma'am?
Pardon?
Full screen mode, slideshow mode.
Slideshow.
It is slideshow only on my screen.
No, ma'am. We are seeing the entire PPT slide.
Oh, I don't know what happened.
We can leave the meeting and rejoin again. You can try that also.
Okay, that will be.
Yes, ma'am.
I'll try that.
Yes, ma'am. Yes.
Are my slides visible now?
Ma'am, it is still not on full screen mode. And there are 3 buttons.
Now?
Yes, ma'am. Now.
Yeah.
Okay. Really sorry about it.
No problem.
Wait, can't help.
So as I mentioned that vectoral association is quite a common association, and we do come across it once in a while. So whenever we are presented with a case of tracheoesophageal fistula, we should actively look and rule out other anomalies which may be associated. So these may be vertebral anomalies ranging from scoliosis, hemivertebrae and all, sacral agenesis, these all may be associated. Then anal anomalies. Many a times we get cases of tracheoesophageal fistula with anal imperforate anus, and both surgeries are planned together, so they add to the complications. Then cardiac anomalies are present in 20% of the cases. Renal anomalies and limb anomalies may be associated. So prenatally, the child may have polyhydramnios and absent or small stomach bubble in the prenatal ultrasounds. Then at birth, we will be unable to pass the suction catheter. There will be a triad of excessive salivation, choking, and cyanosis with the feeds. And I have already discussed how to do the differential diagnosis among the various types of TEF. So pathophysiology, the most important pathological aspects are the aspiration, possibility of aspiration, and the child will present to you in a dehydrated state, and there may be pneumonitis and very poor chest compliance. So it is very important to urgently diagnose and treat this condition. So in preoperative antenatally, we can diagnose the condition with polyhydramnios, absent stomach bubble, and upper pouch sign. Upper pouch sign is basically a dilated upper upper esophagus. MRI will there will be a non-visualization of the intrathoracic segment of the esophagus, and however there are high false positive rates of prenatal detection. Then postnatally, we will see the triad of clinical symptoms, then inability to pass the catheter, then H type of fistula will present to you with recurrent chest infections. Then various investigations like radiography can be done. And then radiopaque studies are now not advocated because of the risk of chemical pneumonitis. And we have better modalities. Ultrasound can diagnose other associated anomalies. Now, imaging, this is a case of tracheoesophageal fistula with upper blind esophageal pouch, and you can see the coiled coiled nasogastric catheter. This is the small stomach bubble in the ultrasound, and this is the dilated upper esophagus in the as a pouch sign in the prenatal ultrasound. So, coming to the preoperative management of the child, the neonate should always be managed in a tertiary care center with NICU facilities. The child should be adequately hydrated with isotonic fluids. We should protect the lungs from aspiration pneumonitis by intermittently suctioning the upper pouch and maintaining a upright position. Previously, semi-prone positioning was preferred. Now it is just a upright position and intermittent suctioning of the and continuous irrigation of the pouch. And for pneumonitis, antibiotics have to be administered. So this is a Rapoglay tube. This sometimes the postgraduate students are asked, though it is not frequently used in all the centers, including ours. This has a radiopaque double lumen tube, which has a blind ending pouch for continuous irrigation and suction. You can see there are two lumens. From one, the saline comes out, and from other, it is aspirated out. So the plan for surgery, the child may be posted for as an emergency surgery with gastric distension, which is compromising the ventilation. So lung compliance will be very poor in this condition, and there will be a presence of gastric content, which can be there can be a risk of aspiration. In stable neonates, the surgery can be done after 24 hours but before 72 hours. And staged repair is done in children who have multiple comorbid anomalies after a stabilization, in between stabilizing the child. If gasless abdomen, which is suggestive of a proximal or absent fistula, preemptive gastrostomy is done, followed by delayed repair, and cervical esophagostomy for the egress of the saliva, or diversion or gastrostomy or absent esophagostomy. abdominal esophagostomy for feeding is done. So the major challenges in this case are aspiration pneumonitis, associated congenital anomalies, over-distension of the stomach, leading to an inability to ventilate, and post-operative intensive care. Pre-anesthetic concerns are whether the child is premature or term. Then diagnosis and type of fistula, we should elicit the history and we should find out what kind of fistula is there. Then associated anomalies and associated comorbid problems and severity of the pulmonary involvement. Then risk stratification, we should stratify what risk category the child falls in. Then type of surgical correction which is planned, whether it is open or whether it is thoracoscopic, and preoperative intubation, whether the child needs a preoperative intubation. So lab investigations, basic investigations like hemogram, serum electrolyte, RBS, RFT, these are done. Then chest X-ray and ABG may be done. Chest X-ray is always done to identify the current lung condition. And ABG may be done in cases, especially where there is a requirement for one lung ventilation to determine what extent the OLV will be tolerated. And then echocardiography may be done to rule out coexisting cardiac anomalies and to rule out the vascular anomalies, especially the presence of right aortic arch, which will modify our surgical approach. Then ultrasound study may be done in cases where there is a suspicion of associated anomalies, like ultrasound KOB and CNS ultrasound to rule out intracranial hemorrhage in sick children. Then there are various risk assessment scores like Waterston classification, which was based on birth weight, pneumonia, other congenital anomaly. This was a relatively old one. Now there are other proposed which are more commonly used. This is one a simple classification by known as Monterey classification, which is based on congenital anomaly and need for mechanical ventilation. In group 1, there is an isolated major anomaly, dependence on mechanical ventilation, and presence of non-significant anomalies. In group 2, there is a presence of severe congenital anomalies or dependence on mechanical ventilation with one major anomaly. So this will determine the postoperative mechanical ventilation and the risk. Then there is a Spitz classification, which is the commonest one which is used worldwide. So this is basically group 1 is a birth weight of more than 1500 grams. There is there is a no major cardiac anomaly, and survival rates which were reported earlier were 97%, and later on revised survival rates are 98%. For a birth weight of less than 1.5 kg and presence of a major cardiac anomaly, the survival rates reported earlier were 22%, and now the survival rates which are revised due to the presence of better technological advancements, the survival now is up to 50% even for these children. Now this is another commonly used classification which is the latest one, that is Okamoto classification, modification of Spitz classification, where the class 1 is no major cardiac anomaly, birth weight of more than 2 kg, the risk is low and survival is reported up to 100%. And class 4 here is the major cardiac anomaly, birth weight of less than 2 kg, risk is very high and survival is only 27%. What is the difference when there is a cardiac lesion versus a child which has no cardiac lesion? Presence of any vascular anomaly like a right-sided aortic arch can affect our plan of patient positioning. Surgical approach may change from right side to left side, and it will also affect our ventilatory plans. Then cardiac lesions which have a associated high pulmonary blood flow like VSD, there we can usually proceed safely with surgical correction, because in initial first month, initial few days especially, the child has a very high pulmonary vascular resistance. So these lesions generally do not increase the risk of the child. However, if there is a significant duct dependent circulation, the child duct has to be kept open by prostacyclin infusion, and then we proceed for the surgery. And this child has a significant risk of mortality. So we may need to resuscitate the child first. Now coming to intraoperative monitoring, standard ASA monitoring, in addition to the standard ASA monitoring, we can apply precordial stethoscopes, which will help the breath-to-breath monitoring of the ventilation and determine the ventilation to the dependent lung. So also sometimes the tube may migrate, there are other complications which may happen. So this will be helpful and it can be fixed to the left-sided axilla in the right thoracotomy position. For upper and lower extremity, 2 pulse oximeters should be applied in all the neonates, but especially in the right to left kind of shunt anomalies. So the one of the pulse oximeters should be applied to the right upper limb, and other can be applied to the other 3 limbs. Then arterial access can be obtained. For the initial 1 to 2 days, we can obtain a umbilical access. Otherwise, we can take a radial access. And it is generally indicated in children who have significant congenital heart disease or lung disease, and children who are unstable. And urine output can obviously be monitored. Then intraoperatively, most commonly right posterolateral approach is used, and this is the position with the right upper limb going over the child's head, and the this ribs open up in this position, and there is a small pillow, small thing is used for below the right axilla to open up the below the left axilla to open up the ribs. This is the characteristic position for the right posterolateral approach. And left lateral decubitus position and extrapleural dissection is the approach through the 4th to 5th intercostal spaces. We have to pay attention intraoperatively, vigilantly. We have to monitor the airway pressures, tidal volume, and end-tidal carbon dioxide. And we have to prevent hypothermia. We have to re-expand the lungs slowly when the case finishes to eliminate atelectasis in the non-dependent lung. Then coming to the intubation techniques, the most common technique used in our institution and as per my knowledge in rest of the world is the apneic intubation with the use of a muscle relaxant, because it provides optimal airway condition with minimal stimulus. And however, the problem here is need for positive pressure ventilation, which may not be tolerated in children who have a very poor lung compliance, and there it will lead to distension of the stomach and further impede the ventilation. So we have to carefully select the children. So here we have to use a controlled RSI with a gentle positive pressure of only less than 12 centimeter of water. And the type of tube should ideally be a cuff tube without a Murphy's eye, such as a microcuff tube. And position of the tube is ideal position is the tip should be below the fistula and above the carina. Now, airway management, awake intubation with topicalized airway has also been described. And some cases only inhalational sedated intubation without the use of muscle relaxant is also applied, has also been used. This all choice will depend on the size of the fistula and the compliance of the lung. So awake intubation, it has been advocated that you topicalize the airway. However, the limitation is that first of all, we have a limitation of the local anesthetic dose. Then there are disadvantages of trauma in a moving child, poor glottic view, desaturation. Intracranial hemorrhage is a significant disadvantage. So awake intubation has been, totally abandoned. Now, intravenous or sedated intubation, which is known as, it is preferred under spontaneous ventilation, because the ventilation is preserved. We do not need any positive pressure ventilation. So negative intrathoracic pressure will allow the gases to enter rather than the enter lungs rather than the path of least resistance, that is tracheoesophageal fistula. And there is always an option of awakening in case we have any life-threatening situation. So in poorly compliant lung, however, it will be difficult to maintain the gas exchange. So the main concern with whatever technique we use is to pass the tube distal to the fistula and keep it slightly above the carina. So commonest technique which we use is generally a deliberate endobronchial intubation on the right, which usually goes to the right side. And then we keep a stethoscope over the left thorax and we keep withdrawing the tube millimeter by millimeter. And as soon as we get a air entry over the left thorax, then we know that the tube is just above the carina. So this is the commonest technique used. And another techniques are that we can use flexible fiber optic bronchoscope to guide the tube just above the carina and beyond the fistula. We can also use preoperative after intubation. After induction, we can use a rigid bronchoscopy, which is used in some centers to localize the exact point of fistula. Then if gastrostomy tube is present, we can place the end of the tube under the water seal, and bubbling will stop whenever the ETT is below the fistula. Then then coming to the options which have been described in the literature, the advantages and disadvantages of various options. Maintaining spontaneous ventilation, I have already discussed that it avoids the positive pressure ventilation down the fistula, which avoids the gastric distension. And disadvantage is inadequate ventilation during thoracotomy. Then placement of the endo, here we maintain the spontaneous ventilation till the fistula is ligated. Then placement of the endotracheal tube below the fistula, which is a very simple procedure, but may not be possible for fistula which are paracarinal. And you will be you may be surprised to know that majority of the fistula, a very large number of fistula are paracarinal, within 1 centimeter of the carina. So gastrostomy to decompress the stomach is done sometimes in cases where there is a very large fistula. So this reduces the gastric distension and atelectasis. However, it may lead to increase in oxygen flow through the fistula. And then electively intubating the left main bronchus. This can be done for one lung ventilation. It bypasses the fistula very effectively. And surgical retraction of the right lung will be easier when the tube is totally into the left bronchus. However, the lungs may not be in that good condition to tolerate the one lung ventilation, and hypoxia will be frequently seen, and it will be difficult to place the tube on the left side. Occluding the tracheoesophageal fistula with a Fogarty embolectomy catheter or bronchial blocker are a better way of isolating the lung. And even the tracheoesophageal fistula can be retrogradely occluded by using a Fogarty catheter through the through gastroscopy through the gastrostomy tube. Then emergency TOF ligation is another effective way of ventilation, achieving good ventilation. Emergency ligation of the gastroesophageal junction can also be done. However, there is no single best anesthesia technique which is defined, and anesthesia technique obviously has to be individualized based on the patient condition and other characteristics like the fistula diameter. Then positioning of the ETT, we have already discussed this. This is one case where I was almost facing a inability to ventilate even after placing a tube. So what I used a microcuff endotracheal tube and placed it as distally as possible. It was a large precarinal fistula, and then inflated the cuff when I could feel that it was in the above the carina. Then I inflated the cuff, and it effectively sealed the fistula. So we were able to rescue this situation from further worsening. This is another concern, as I have already told you, that a large number of fistula can be pre or paracarinal. So in a study on 113 neonates, Holsky et al. Found that 22% of the cases, the fistula was within 1 centimeter of the carina, as in my case. And in 11%, it may be even bronchial. So in these situations, if we do that withdrawing technique, even that technique will not be effective. So bypassing may not be possible. Some people say that in a small fistula, even keeping the tube mid-tracheal may be effective. And if possible, we should always use preoperative bronchoscopy in TOF cases to whether it is flexible or rigid to effectively manage the airway. So surgical manipulation of the lung by retraction or CO2 insufflation can alter the hemodynamics and lead to VQ mismatch. And accidental fistula intubation can lead to a sudden and very fast gastric insufflation and inability to ventilate. Then accumulation of blood and secretions can occlude the endotracheal tube. And we should always check the fistula after ligation by manual positive pressure ventilation. And endotracheal nasogastric tube should be firmly fixed after a repair. So intraoperatively, the complications which we may face is interference of the ventilation by kinking or displacement of the endotracheal tube into the fistula, or even the bronchus may be kinked. And obstruction of the endotracheal tube with blood secretion, VQ mismatch due to lateral decubitus position, and retraction of the non-dependent lung. Vagal response to tracheal manipulation may be there. and the child may return to transitional circulation and shunting due to any intraoperative factors like hypothermia, hypocapnia. All these factors can lead to sudden transition to the transitional circulation, return to the transitional circulation, and sudden massive desaturation and hypothermia. Now, what are the possible complications in this deaf child? We have mentioned about the intraoperative complication. Then there can be vagal response to tracheal manipulation, and there can be hypothermia. These children can land into, these are neonates and they have neonatal concerns also. This is one case which was interesting, which I faced this complication of inability to ventilate after intubation and positioning. What happened was that they insert this red rubber catheter for localization of the upper fistula. So this red rubber catheter, in this case, it was a very big catheter. It was a 12 gauge catheter which was inserted rather than their usual size of a smaller one. So this catheter, in fact, this catheter led to a pressing of the pressure over the trachea and the tube, and the tube got compressed, and we suddenly lost ventilation. So we have to be very vigilant, and we have to see all the possible reasons of any difficulty in ventilation. We have to see what stage the surgery is, and we have to see all possible causes. So now another approach can be thoracoscopic repair. The patient is positioned, the position is very different. In this case, the patient is positioned prone with a wedge below the right chest, and operative pneumothorax compresses the ipsilateral lung. So there can be desaturation and fall in venous return. This is a major concern. Generally, very healthy neonates tend to tolerate it very well. However, the children with cardiac anomaly or other pneumonitis, they may not tolerate this procedure well. And CO2 absorption can lead to hypercarbia and acidosis. In most of the cases, they do not ask for one lung ventilation, we should remember. And the introthoracic pressure is only 4 to 6 centimeter water. Even with this pressure, we are able to achieve a good lung retraction, and they do not generally ask for a one lung ventilation. So the advantages of thoracoscopic surgery is it is a minimal access surgery, minimal damage to the muscle, so leading to less amount of pain, and there can be a potential reduction in the musculoskeletal sequelae which are associated with the open approach, like wing scapula and scoliosis. Disadvantages are that there is a high learning curve, there is a cost, and it is difficult in babies less than 2 kgs and those with significant lung disease. And insufflation of CO2 can lead to hemodynamic compromise, and high pressure in the thorax can lead to decrease in cardiac output, and obviously pleural cavity is breached. So coming to the analgesia techniques, we always go for multimodal analgesia. For neonates, the NSAIDs are not possible, so paracetamol should be given. If a preterm child, then we can go for 7.5 mg per kg. And in a term child, we can go 10 to 15 mg per kg. Then regional anesthesia is possible. It is very much possible and very, very effective. We use it for all the cases. If nothing else is possible, at least local infiltration everyone is doing. Then intercostal block is very, very simple. Fourth and fifth ribs are open space, intercostal space is used. So 2 spaces above and 2 spaces below, we can give the block. Then paravertebral block either given preoperatively by ultrasound or by the even infiltration in the paravertebral space by the surgeons is very effective. Intrapleural infusion of local anesthetic has been reported. And caudal catheter is a very, very effective approach. If it is done, the catheter is threaded up to the thoracic level. And thoracic epidural, I am sure very few people will be doing it. It can be if caudal catheter, we should ensure that the tip is in the mid to high thoracic level by localizing it by ultrasound. Then opioids and non-opioid analgesics like other adjuvants like dexmedetomidine, all these, and dexamethasone, all these can be used. Then post-operatively, we have to decide whether to extubate or not. So that decision will depend on multiple factors, including prematurity, weight, comorbidities, ease and duration of surgery. There may be a tension in the anastomosis, which is reported by the surgeon. There we will be cautious in extubating. We will avoid any pressure over the anastomosis. We will avoid any extension of the neck. So generally surgeon in such cases will prefer to keep the child intubated. Quality of the pain control, we have to decide whether the child, we are able to achieve good analgesia. Then ventilation is generally indicated for neonates who are less than 2 kg, who had preoperative poor lung compliance and respiratory distress, who had significant cardiac pathology and repair was done under tension. And NICU stay is done generally for monitoring effective pain management and ventilation. So post-operative complication, early complication can be an anastomotic leak, which can lead to mediastinitis. It is possible after 7 to 25% of the open thoracotomy, and thoracoscopic 17 to 36%. So we have to be vigilant in the post-operative stay of the child about the lung compliance and other condition sepsis features. Then esophageal stricture at the site of anastomosis is a very high incidence of 30 to 40%. Recently, I faced a very interesting case where the child had undergone a surgical repair of the TEF around 1 week back, and the child was later on again shifted to us for a unrelated abdominal condition. And when we intubated, the child had a significant, very severe tracheobronchomalacia. And we faced a very, it was a very difficult condition, difficult thing. Intubation was easy, but ventilation became very difficult. So we have to be aware that the child who has been recently been, operated can have these kind of complications. So tracheomalacia is associated in 10% of the cases. And then feeding difficulty, esophageal dysmotility, these all, and gastroesophageal reflex, it is very, very common, 40 to 60%. And that can also lead to aspiration pneumonitis. So thank you very much. Wishing you all a Merry Christmas. And thank you very much, ICA, for this opportunity to present the talk at this esteemed platform. Thank you very much.
Thank you, Dr. Anju. So we can take the questions. So, Vineet, do we have any questions in the chat box at your end?
No, sir. Only thank you message from Mudhir Kanchi, sir.
Oh.
So Dr. Anju,
Yeah.
so how frequently?
Very sorry for the technical glitches.
No, it was absolutely fine. These all things keep on happening. Not an issue at all. So Dr. Anju, in your setup, how frequently are you using fiber optic for these cases?
Actually, we are not using fiber optic or rigid bronchoscopy. Nobody is using. But when I was in Safdarjung, actually, I started doing fiber optic bronchoscopies for tracheoesophageal fistula for my own interest. And seeing this, the surgeons, they gave a thesis on this. So then they were doing it routinely. So, and to my surprise, actually, the fistulas were located paracarinal. So many fistulas we could see paracarinal.
Right, right. Many of them, actually, they are very difficult to manage also.
Yeah. I shared a case of very large fistula. In fact, I discussed with the surgeon. He told me that when he located the fistula, he told me it was a 7 mm fistula, which is rarely there. So it was a very wide fistula, and we were almost, there was an inability to ventilate till I inflated the cuff and we were able to restore, the ventilation was restored. So cuff tube may be a good idea in these cases.
Right. Dr. Bhuvaneswari,
Yes, ma'am.
for your pre-medication, what do you usually use? For example, you have a child, 3-year-old child, and he's supposed to do surgery without an IV access, and you had no time to give any oral pre-medication. Might be just supposed to in another 10 minutes or so. How do you manage those cases in your setup?
So we have that play area which I have shared the pictures of, and generally we talk to them and we get the parent till the outside the operation theater. They come in those toy cars and stuff. So they are quite engaged with us. They walk and talk with us. So generally we don't need any pharmacological pre-medication in such cases. That's how we've been managing.
So do you also allow the parents inside the OT?
Not in the OT.
Okay.
just outside the operation theater till the line of sterility begins.
Okay.
So
Okay.
till there we allow the parents, and then we bring the child in from there. So it's hardly 10 steps away then from there.
Okay. 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 Thank you. Dr. Nishkarsh, any more questions?
So there are not many.
Basically, they had an excellent presentation, 3 of them.
Yes, and it is an interesting topic, and pediatrics is something, especially the neonates and infants. It is a different ball game. They are not small in adults, so we have to be really precise in managing these cases.
Right. Dr. Vinit, I think
And anyone else, if they are using pre-medication, like we are routinely using oral pre-medication with ketamine and midazolam in Sir Gangaram Hospital, and at times we are forced to allow parents inside the operation theater till we are able to pacify the child and even induce, especially in emergency hours, because we have very less staff available at that time. So we do allow that. Nishkarsh sir, if sir can shed
At
some
our
light.
setup, we do a lot of pediatric sedation,
Yes, sir.
especially radiotherapy, the smaller children. And they have to go typically about 20 to 25 sessions in a month. So basically, it is a 5-day in a week to 4 to 5 weeks in a trot. So these patients, the ketamine does help. So it depends. So if it is, if you're talking about oral pre-medication, we have used ketamine 4 to 6 milligram per kg. But
Yes,
the
sir.
problem is that it is bitter, so we typically mix with paracetamol, the strawberry flavor or whatever flavor the children like, and that mix with that flavor, it allows them to have it. Only problem with oral ketamine is that the duration is quite prolonged. Or you have to keep them under monitoring for some time because it doesn't offset very fast. It is slow to onset and takes its own time. So that is our little challenge. And midazolam we have used. In fact, we have used intranasal dexmedetomidine and intranasal midazolam as well. We have that in our setup nowadays. So that has also shown a good response. So we can actually tailor depending on the need. What Bhuvaneswari said is a good option. So this can be a good addition to pre-medication if required. So patients have their own needs unique to them. So we have to mix and match the things and have a setup ready for pediatrics as well as give drugs to the advantage.
Yes, sir.
Cool, sir.
We do use intranasal dexmedetomidine a lot. And 2 mic per kg, we are using intranasal. But we have seen that it does delay recovery in many short cases. If they are like EUAs and all, it does delay recovery to some extent. We have to monitor for some time. We also have midazolam spray available, and in some theaters, we are using that. Otherwise, we use oral midazolam very frequently.
Right. Can I add something here?
Yes, ma'am. I was just coming to you. Amrita ma'am will enlighten us about the practices of PHU. Yes.
Yeah. So for actually what happens in our setup for major surgeries, we take the patient 1 day prior on IV and we start on maintenance float. Okay. So for especially those cases, maybe a short procedure or they're coming on a OPD basis for mild sedation and all, these are the category in which we are like, we time the time of the surgery just 20 to 25 minutes prior. We mix midazolam 0.5 mg per kg
Yes, ma'am.
in sugar syrup. And I try to keep as much as low possible. Like suppose it is 1 ml, I will make it to 2 ml or maybe just 3 ml. And then we make the baby. We use only midazolam.
Okay.
Any lollipop I have used, but I didn't see any much promising result with that.
Yes, ma'am.
Yeah.
Actually, problem with oral drugs is that sometimes children are really cranky in the pre-op period and it is not easy for us to give them pre-medication drugs. So they howl like anything. Especially in our setup, when they are coming for 30 days, so they know what is going to happen. Even the radiotherapy procedure is about say 2 minutes, less than 2 minutes. whole process is about 3 to 4 minutes, but actual therapy is about 30 seconds to a minute. So basically, it becomes a real challenge, and that IV line also is there for 2-3 days. Change it every few days unless there's a central line in place. So these children are really tricky to manage. Because the problem with sugar syrup or any other additive is it's still the bitterness remains. So I'm not sure how many of us have tasted it. The midazolam and ketamine are really bitter, so it is not easy. They're not palatable actually. So that is a big challenge, and we don't have customized oral drugs to give. So for that reason, the intranasal comes to a rescue, because the absorption is really fast, and they're not dependent upon, because child will not spit easily and those things, and the absorption occurs. So that can be tried.
Yes.
Give it to the parents, sir. So we make the syrup. Though we stay there, we hand over to the parent and we let them drink. So what they do is like if we mix, or sometimes we keep it separate. Thoda sa dila diya sugar syrup. By that time, then we give we keep it in 2 ml syringe ready, and we just push with the pistol. Then again the syrup. So that combo works. That is how we do.
Yes, we are also mixing it with dextrose usually.
I think
We can also
distraction
try.
technique also helps a lot. My pediatric anesthesiologists do
Yes,
so
ma'am.
well in
Patanjali
that.
ma'am is an expert. Yes.
Yeah. Achha, what about Emla cream? How often are you all using that?
Ma'am, we are using Embla cream on children where IV induction is indicated, like children who have seizure disorder and all. So we apply Embla cream and we secure the IV in the lap of the parents. So that we do.
So not as a routine
Not as a routine, ma'am.
Achha, okay.
Ma'am, regarding the midazolam, I had done actually a study, and I used to mix it with apple juice, and it was quite palatable. So what I used to do is there used to be a cap on the IV fluid bottles. So I used to mix the 5 mg per ml midazolam with the apple juice, and it was quite well accepted by the children. They did not spit in a single instance, never. So that I found to be much more useful.
Useful. Yes, ma'am. So, ma'am, there are no questions. So,
Right.
People are celebrating Christmas.
नहीं, Anju, पता है क्या? Many of them see the YouTube later on.
yes,
Yeah,
ma'am.
I know, ma'am.
उसके बाद then I
That
think
is
your
that is
email
a big
address.
deterrent to live attendance.
So then you'll get the questions later. And of
Yeah.
course, Christmas is there, of course, but we've noticed कि YouTube में बाद में जरूर देखते हैं. So I think all the 3 topics were very, very challenging. But of course, the first thing, that is pre-medication and getting the baby inside, is the most challenging part. And then, of course, once they come into the recovery as well, at that time also you want a quiet baby. But very challenging topics, so well covered by Bhuvaneswari, Amrita and Anju, and well moderated by Chandni and Nishkarsh. Thank you so much. And we really enjoyed the webinar, and I'm sure the students did as well. So thanks a lot, and hope to see you again, and wish you all again a very Merry Christmas and a Happy New Year. Thank you so much, and God bless.
Thank you so much, ma'am. Merry Christmas and Happy New Year. And to your little one also.
Yeah, here she is.
Ma'am has 2 separate calls.
Thanks, Vineet. Thank
Yes,
you
ma'am.
so much.
Good
Thanks
night.
a lot.
Thank you,
Good
ma'am.
night, ma'am.
Thank you.
Thank
Good
you.
night, everyone.
Thank you so
Hope to
much
see
to
you all
all
Wishing you
again.
all a
for
very
your
Happy New
wonderful
Year.
deliberation
Thank you.
and your informative content that you have shared to make this session a success. It was a pleasure to host this session. See you again. So with all your due permission, we will be ending the session in here. Have a good night and Merry Christmas to all.
Thank you, Swastika.
Thank
Thank
you.
you.
Thank you.
Thank you so much,
Bye.
ma'am.
Bye.
Good night, everyone.
Good night.
Thank you. Good night. Bye.